Well, thank you and welcome to this additional session sponsored by AOTI, which is looking at the new Vascular white paper that's come from the all-party Parliamentary group, and which is a call to action to change government policy. What we want to try and do is develop the reform of vascular services across England, so that we develop the lower limb services across England a lot more. I'm going to do a very short presentation of about sort of 5 or 10 minutes just to set the scene, and then we're going to have a national roundtable to ask how can we socialise this new call to action, and then how can we inform government policy. What will be the actual nature of doing this? Stella Wieg, who's a vascular surgeon and the national lead for secondary care, was supposed to be here. I think because of a strike, the tube strike, he hasn't been able to make it. So I do apologise for that. But the session will be recorded, and many of us know her, and we will be badgering her to try and change as much as she can. So I'm just going to head to the table to ask to do a very short presentation. So I just want to thank AOTI for providing this market access data, which looks at lower limb ulcer care and the hospital burden of lower limb ulcers. So the first thing to say is that they collected data looking at foot and leg ulcers and bed days within England in the adult population, and essentially the prevalence is about 59 per 100,000 admissions, so a significant burden. What that equates to is about 27,000 episodes of care every year in England for people who are admitted with lower limb ulcers. And that, over the last sort of 4 or 5 years, hasn't changed. The burden is significant. This ties into the new paper that was published about 3 or 4 months ago, which looked at 20,000 ulcers across England and Northern Europe, and showed that over 7 years there was no improvement in ulcer care in the community. And whilst there is no real change across England, there is a north-south divide again. So the regional prevalence is higher in the north of England compared with the south, and it's up to 10% higher in the north of England compared with the national average. And in southern England, the prevalence is lower than the national average. Now let's look at diabetic foot ulcers, and this is a really interesting slide. The prevalence of diabetic foot ulcers is about 126 per 100,000 diabetics across England, and the prevalence of the non-diabetic foot ulcers is about 33 per 100,000. So the diabetic population is significantly higher risk and a much greater prevalence of admission compared with the non-diabetic population. However, and this is a really important point, what is the actual number? So we know that roughly there's about 4.5 million people who are diabetic, and of that about 126 per 100,000 are admitted, and about sort of 40 odd million are not diabetic. And if you look at apply the prevalence to that, there's about 5,500 admissions for diabetic foot ulcers and 13,000 admissions for foot ulcers in people who are not diabetic. So although the risk in diabetes is much greater, non-diabetic, the actual use of service is actually much greater for non-diabetic foot ulcers. And again, for major amputations, the risk of an amputation, the prevalence of amputation in the diabetic population is much higher. And it seems to be reducing, as was shown in some other data as well. And the prevalence of major amputation in the non-diabetic population remains the same at about 4.5 per 100,000. But again, if you look at the numbers, about 2,500 major amputations are in diabetics and about 2,000 are in the non-diabetics. So about 45% of all major amputations are in people who do not have diabetes. And again, there's a north-south divide when it comes to major amputation, has been described previously. Now, all this data about ulcers are people who are admitted with a primary diagnosis of an ulcer. So these people have probably got foot and leg ulcers, generally been infected, and the primary cause of the amputation was the ulcer. But the diagnosis code for an ulcer spreads across 10 diagnosis codes. So often these patients have multiple comorbidities. And these multiple comorbidities, if you look at the multiple comorbidities, the actual use of services of ulcer patients, it's about something like 10 times greater if you look at all the comorbidities for patients with ulcers. And that's an important thing which I'll come on to in just a second. And that is that ulcer patients are the canary of the system. If we want to improve cardiovascular disease, respiratory disease, and diabetes, we need to improve their comorbidities as well. And if we can improve the comorbidities not just of the ulcer, but of the comorbidities of these patients, you can reduce hospital admissions as well. So what will that look like? If over 5 years we can reduce the prevalence of admissions by 30% of patients with ulcers, we can save 66,000 bed days across England every year. Now, one of the great things that AOTI have is that they've got this data for every ICB and every trust in the country, and if you have a chat with them, they will help you get data for your local area. And basically, if we can, across Greater Manchester, where where I work, if we can reduce ulcers by 30%, we can release 4,000 bed days, and that's a big currency nowadays. I'll save about £1.6 million. And we can break that down by hospital trust as well. So within Greater Manchester, the trust I work at, for example, if we reduce it by 30 days, we can save over 1,300 bed days per year, or about 4,000 across the region. And in Greater Manchester, we've got about 6,000 acute beds, so we can reduce it fairly significantly. And if we look at nationally, if we reduce 30% of admission in all these patients, we can save up to 1.4 million bed days by optimizing their diabetes as well as their comorbidities. So if we see ulcer patients as a long-term condition as well as all the other long-term conditions, we can make significant savings. And a similar work example, if you look at all ulcers and their comorbidity, we can save about 4,500 bed days, release about £30 million of capacity. And that's a trust breakdown within Greater Manchester as well, which is, we can save up to 76,000 bed days a year if we improve everything by 30%. Now I'm just going to briefly mention, with that as a background, what we want to try and do is use the Vascular white paper by the All-Party Parliamentary Group, which was a call to action to try and change things. And I'm just going to hand over to Roger, if I may. Can we get a microphone to Roger? Roger is the part of the Secretariat for the All-Party Parliamentary Group, and he was convened the expertise from around the country for what these recommendations are, which are briefly, I don't want to steal your thunder, to implement a national foot attack pathway, to establish foot protection services in every ICS, to set national maximum waiting times for treatment, reform commissioning, and to accelerate proven innovation. I'm going to hand over to Roger very briefly, and then we'll start the discussion of how can we actually socialise these recommendations.
Perfect, thanks Naz. Do you want me to do it from up there? Yeah. Not that everyone needs to see my face, because that's not exactly what anyone needs on a Thursday afternoon. Yes, my name is Roger Greer. I manage the Secretariat for the Vascular and Venous All-Party Parliamentary Group. Many of you might ask, what is the Vascular and Venous All-Party Parliamentary Group? It's a group led by parliamentarians, so MPs and Lords, to basically raise awareness about vascular disease across the country, particularly in Parliament. I'm not a vascular expert. Tom was on the last panel as an orthopaedic surgeon. He maybe feels out of place in here. I feel even more out of place in here. I'm not even a clinician. But what I am good at is kicking MPs up the backside and getting them to care about stuff. Because they have very little bandwidth to think about anything other than exactly what's happening in front of their eyes in that moment. And if you're watching politics at the minute, you will realise that there is a lot happening in Parliament that can take up their attention. And I think that's the challenge. I mean, you all know the issues in the sector. You all know the issues for patients, for yourselves and colleagues as clinicians, and for the system as a whole. Naz had some really interesting stats in his presentation there about the ability to save bed days. Parliamentarians won't know this. They won't know all of these challenges. They won't know all of the solutions. But you do, and they've been said 100 times. I've sat across a couple of the workshops and a couple of the lectures in here today. And it was really interesting, the consensus around what needs to happen to change practice, to get better outcomes for patients. But parliamentarians don't see that. The department doesn't see that. And I think that's been a big problem for the vascular sector. I've said it, I was chatting to Marcus outside before I came into this little session. Vascular is the AOB of cardiovascular. And it's been that way for a long time, and it will remain that way unless we all do something about it. And about a year and a half ago, Stella Vig gave me a call and said, I think we've got a moment. We've got the 10-year health plan coming out. We've got a new Secretary of State. We have a parliamentary majority of 100-odd MPs, and there's an appetite to make change. I don't care who does it. I don't care how it's done, but we need to make change right now. And that led us to develop the white paper with some of those recommendations you see on screen. So we held a roundtable in Parliament in October to develop the consensus around what the recommendations should be, and then we published that white paper earlier this year. We held a sort of follow-up to that in February, where many of colleagues at the table sat around and we worked out actually what do we need to do to make this real life? How do we actually change practice? What do we need to do for the system? How can we provide some collateral and some written work that supports the system? We're trying to do that at the minute. But the key recommendations, as you'll see from the screen, is fund and implement a national foot attack pathway. And Mike talked really eloquently about why the foot attack service is really important. Establish a community-based foot protection service in every ICS aligned to national standards. And I think with the drive to community, the drive to prevention with the Department of Health at the minute, that's a really important piece. Have maximum wait times for assessment and revascularisation. I was talking to colleagues at the back on how important it is to have really early diagnosis, really early assessment, really early treatment. And, I mean, you all know this. MPs will probably get the concept, but they don't know the impact. They don't know the impact that has for patients every single day, that you all see every single day. We want to reward good outcomes, like anything else in the NHS. The NHS hates two things: the way things are and change. So if we want to get them to change things, we need to make sure that they're rewarded for doing so, and also accelerate the adoption of technology to support that. We've heard some of the talks today about how some of that technology can really embed better outcomes. I'll close by saying politics and policy and opportunity are really volatile. And it's really, really volatile at the minute. Stella was right when she said a couple of 18 months ago, we've got an opportunity right now to do something, and I think we still have that opportunity despite what's happening in Westminster and Whitehall. Collaboration on this is absolutely key. 1 times 100 is not the same as 100 times 1. If 100 people all have their own distinct message, their own distinct ask of government, they will hear 100 different things. If the sector speaks with one voice around the white paper, around the consensus that we built over the last year, they will hear one message from 100 people, which is much more impactful. The report, the recommendations on screen there, that's the first step in this. When we held the roundtable in October and the follow-up in February, it wasn't as a pat on the back. It was this is the first step in the process of making change, and we really want to do that. And visibility, consistency, and urgency are all key for that. I saw a tweet at Christmas time. I spend a lot of my life on Twitter, which is for shame. And it said you should be able to describe your job in 1 sentence to a 7-year-old. And I found it quite difficult because as a public affairs and government affairs practitioner, that could be quite complex. But the best I could come up with was I talk to government so people don't have to shout at government. I think we should still shout at the government, and I think using the tools in the white paper and the group that we've assembled, we can really make some change. The VVAPPG is holding a drop-in on the 18th of May. You're all welcome to come, get in touch, and I will get you an invite. There are some written bits of a campaign which have been in the media. There was in the Daily Mail a couple of weeks ago. In the Vascular News edition that's in everybody's bag whenever you come in, there's a piece from Rachel Forsyth from the Circulation Foundation on that white paper. But my key message is engage with us. Come and talk to me, see how you can get involved with this, because if we don't do it all together, we probably won't do it at all.
I'm going to sort of open this up to discussion. I'm going to start with Rachel and Keith in your sort of national roles as GIRFT lead and lead for the Vascular Society. Could you give some sort of advice on how you feel that the Vascular Society could help take this forward?
Thank you very much for the question. I mean, we have spent a vast amount of time discussing it. I'll leave it to Rachel to be able to tell us how the state of play is at the present and the likely changes that we might be able to make. We as a society have very much been looking at the potential for generating pilots. Stella came to us in the executive meeting of the Vascular Society in February, and gave us a bit of a challenge and said, look, if you can come up with some pilots to show how you could deliver the management of peripheral arterial disease within the community at a very early stage, making a significant difference in the delivery of identification, pharmacology, preventing progression, then we looked to show how we could embed that within. We've had part of the reason for the white paper was to help support the possibility of peripheral arterial disease getting onto the cardiovascular modern service framework. We think we're there, but we don't know in what format and how much of a presence we'll have. So it's up to us to try and develop some pilots and see how we could deliver, and then look to roll that out. I mean, how achievable that is, maybe based on the background of where we are at the present moment in time, and Rachel's the expert on that.
Thanks, Keith. So I think that change is obviously necessary. I said in the meetings we had with the All-Parliamentary group that I felt that the only way of driving this is with data. Data is really powerful. I have learned from all of my GIRFT work that it really speaks the language that everybody seems to understand. And so if we're going to move forward with a national foot attack pathway, we have to have some metrics that are easily measurable so that we can show how bad we are currently, and show whatever we decide to institute, whatever the pilots are, whatever the things we think we can roll out nationally, actually make a difference. Otherwise, we're not doing anybody any favours. We have to be able to show the politicians, we have to show the patients, we have to show the GPs, we have to show everybody that the reason we've made these changes is because it's made this difference. So I do think agreeing a set of metrics is really important. I did say earlier that in the other session that I felt that it's always been a shame that vascular surgery doesn't have a cancer, because you actually need some national targets and you need to be held accountable for them. The reason the cancer pathway sort of works in this country is because there are people looking at everybody's individual figures to see where the patients are in their pathways and making sure that they're fulfilling them. And we don't have that. But seeing as though CLTI has such a high mortality rate, to me it is a vascular cancer, and quite honestly, we'd save more lives more quickly if we had those targets, or we set targets for that pathway. I do think that the HES data is imperfect, but it's HES data and it's coding from all hospitals, and it is a way of tracking those sorts of things. If we had similar targets to the cancer pathways, I think we could do it. I think there are different resources in different hospitals. You know, we've already heard about the wonderful transformation that's gone on in Manchester, but there are some very deprived, very poor hospitals that are in a really terrible state at the moment, that are, you know, voluntary redundancies across the patch, not allowed to recruit, no funding available for any development, and we have to take that into account whenever we're making a plan, because there isn't a whole host of money out there for new stuff. So whatever we're making a decision about has to be pretty innovative and within the envelope that we currently have, I think.
I'm just coming back on that, the question of data, and I guess this may be a question for Roger, is that what is the language that the government understands, particularly with the left shift and with the call to moving things to the community and prevention? What is the key metric? Because usually, when it comes to the clinical argument, that's already won. But what is it macroeconomics? Is it people back to work? What is the key metric that we should be measuring to be able to bash the government over the head with?
For the, I guess it's split into two. To get parliamentarians to care about it, it's what's happening in their constituency. And if anyone saw the debates at the end of last year on welfare, you'll see that many of the parliamentarians who voted against the changes to welfare had more welfare claimants in their area than they have a majority. So if everyone voted against them who was on benefits, who are now not on benefits, they would lose their seat. For government, Rachel's absolutely right. You have to spend within the envelope, so it's showing how innovatively we can change things for better outcomes without spending a heap more cash. That's predominantly on the mind of the Secretary of State, other than leadership challenge potentially. But they want to see change. They want to see a change within the current spend that they have. The Treasury doesn't have any more money to spend on big shiny things in the NHS, particularly when it's something that's so low down their priority list. I completely agree with you, Rachel, on it needs the cancer, or it needs something, which is why we've sort of framed this around foot attack. We're trying to reframe the debate in language that the department will get the challenge on.
Just bring in Patrick and Professor Edmund as well. I mean, you guys have built services in very difficult circumstances, and the King's Union didn't just happen. It took years of work to develop, and all the expertise that you've developed in very challenging financial circumstances. And Patrick as well, you work incredibly hard, and we all work incredibly hard, but developing a service is hard. And what sort of arguments did you use locally to make things better, and how do you think we can perhaps take that forward? Should we be speaking to our local MP? Should we be speaking to other people? What language should we be using, and how can we use these examples to change things?
I'll go first. Thanks, Naz. We don't have a perfect system in Frimley Health. Girth has come around and they know how complex our network is. So we're at the hub at Frimley. We serve 4 other quite large acute spoke referral hospitals at Basingstoke, Slough, Chertsey and Guildford. So even the MDT diabetic foot teams have various levels of buy-in. So in Basingstoke, we don't have an MDT clinic. We have a corridor of different clinicians. We're expected to get along and do our clinics, and we call each other in. But at Guildford, Slough, and Frimley and Chertsey, there is a clinic, and it's difficult. We've done everything that we can to work in a multidisciplinary fashion, but I've looked at the data, and I've looked at the national data, which was presented this morning very nicely, and I still think that we're not quite winning the fight in diabetic foot disease, diabetic foot complications. And I don't have all the answers, and perhaps it's a bit depressing to tell everyone the news, but that's what it is. We're doing everything that we can. We've got all the toys. We've got a good revascularization MDT team. We've got podiatries now in hospital for most of our units, and there may be a few clues. And I think in the community, I think one of the biggest factors is that there's maybe a drop in the number of podiatrists per 100,000 population, and I think funding's down. The interest isn't there, and people like Martin Fox in Manchester, they're doing lots through the College of Podiatry to try and promote vascular assessments and whatever. So there are enthusiasts, but overall I think that people are coming to us later and later.
Regarding your comments, the hospital administrators are just interested in 2 things: save admissions and get people out as quick as possible. And Ian Chetter this morning wondered why negative pressure got onto the scene. The negative pressure got on because it got people out quicker, as such, without definite evidence. So that's the the present issue. And our foot clinic is constructed, and Hani is here now. We've got 2 procedure theatres. So all our digital amputations now are done by Hani or the orthopods. No admissions, day cases. They're all day cases, no admissions. And I think that is what they're interested in. On the other aspect, your ulcer data is on admissions. It's ulcer admissions. So why do people with ulcers get admitted? Well, they get admitted because they're infected, or they get admitted because they're ischemic. And the answer to getting rid of the infection is not wait for them to get infected, but to heal them. And that's why I think these newer techniques, which Bonnie talked about in the last hour, the AOTI and other techniques, are very important, because a healed ulcer doesn't get infected. And I think that is one way forward. But we also have got to get the access, basically. Yesterday, in going from here to Liverpool for the Diabetes UK, which is go on, I went into a taxi because of the by chance the taxi driver was a diabetic, and we got talking, and he had an ulcer, and he said, "I've got one message for all your friends in the health service: nowhere to go, nowhere to go." That's what he said, and I think access is very, very important. But I think from the practical point of view, let's get the ulcers healed as quick as possible.
I just want to bring in, if anyone from the audience wants to say anything, please raise your hand and we'll get a microphone to you. I just want to bring Anahita in. Probably a couple of years ago, I heard you. We had a discussion. I think it was in Vienna. We had the discussion, and you mentioned that one of the ways to get change is to do something top down. And you mentioned that one of the ways you could reduce amputations in America is to make sure that the services doesn't get paid unless they've done some form of revascularization, some form of imaging, or they've proved that they've done something to try and save their leg, and only then could do it. What do you think we could learn from that to sort of change the system, to actually make the system do something and do like a top-down approach?
I think this is going to be controversial, but it is fact. So with human nature, carrots do not work. It has to be a stick. The problem is, like, even these 5 key messages, I mean, they're very nice and they made a wonderful white paper, but they really don't say anything. Like, take, reform commissioning to award outcomes. Like, it means it's like a ChatGPT sort of spit out, right? It's all in execution. And the problem is, fund and implement. I mean, like I said, this like a 7-year-old could, I'm not trying to be insulting. We have the same problem in the US, but somebody would say this faster. The problem is everything that we're doing is like, how do we do this? This is not our job. Like, I'm a vascular surgeon, orthopedic surgeon. Our job is not to fix the social side of things. That's the government's job. And by allowing this kind of nonsense to happen, we as the people are allowing them to not make it a priority. I mean, how can they even say that? You're telling me that people are dying higher than cancer, which we know. It costs billions of dollars. You guys are already paying like 80% tax. And the government then says, we're not going to, screw you, are you kidding me? So it becomes like there needs to be a little bit more of like a revolutionary response instead of this nonsense of, and then we're going to create a team. We can't do anything. We are the end when the patient comes in already pretty, jacked up. So the beginning is the problem. How did they get that diabetic ulcer in the first place? Because their shoes suck. Why do their shoes suck? Because they couldn't see somebody who was a podiatrist who could put them in the right thing. So what we're trying to do in the States is, money drives stuff for us. So we're a little bit different. So what we're specifically trying to get done is, if you don't get an angiogram before your amputation, the amputation doesn't get paid. Overnight will change. Because what we were doing historically is saying, black people get amputated more than white people. Everyone's a racist, which is not true. What was happening is that people didn't have insurance, and it was a system issue. But regardless of the system, if a patient walks in and the hospital knows it won't get paid without an angio, they'll make the angio happen. They'll make the space, they'll make the time. So what I would be saying is, you're taking it a little lying down. as a country right now. I think you're sort of saying like, we're so used to this, like the government screws up and we are like, how do we fix it? You need to be walking in there, like collectively, as he said, aggressively, the whole multidisciplinary team. It's not on us. Like, why are there should be a podiatrist here, vascular medicine, or infectious disease, because we're all getting our clinics filled with this stuff, and then ultimately demanding that they do very specific things. And those specific things would be, like you mentioned about AOTI, instead of these key asks, like you want to say fund and implement, but you guys already have the money, it's just being put in the wrong places. So you'd say that, AOTI, for example, can be done in the house. If you're saying oxygen therapy works, people are trying to send to hyperbaric, never going to happen. But if you're the NHS, you could say that anyone with a diabetic foot ulcer gets this machine in their house. AOTI, we demand that if you want to be part of the NHS, you have to give it to us at half the price. And then the patients who are, the patients that who then are starting to get an ulceration, the person who's delivering the machinery or something is the one that checks the foot. And then, we get those little heat maps where the patient, if they're even starting to get a diabetic question, come in and see a specialist, and it never gets to an ulcer in the first place. And so it's our job to give a menu to the government. We are just saying, make it better. But you have to tell them specifically, because it's funny, just last thing I'll say, I run a political organization in the States, by the way, called Healthcare for Action. That is, the actions in the title, all run by surgeons and like very aggressive. Just last week, we had 2 sitting congresswomen that came online, and they said to us, this is government. So these are people like, C-level students that, sort of got elected and ultimately get. So it's your job as the surgeon. How could they possibly know? There are other doctors that don't know what needs to happen. So you have to say to them, these are the things we need to have this executed. Now you tell us what your pain points are, and we'll tell you what we can scramble to fix it. And if this is not done by 2030 as a mandate, right, then we have a problem, and we need to have these, like, get these people out of office or something to punish them versus just, again, the carrot stick thing.
I mean, it's lovely to hear an American that I agree with. It's wonderful. Just bring back the political. I'll bring you in, Mike. I mean, one of the reasons we've been able to do stuff in Manchester politically is because of Andy Burnham and Keir Starmer, and that politics has helped us enormously, and that cannot be underestimated. Mike, did you want to say a word?
Yeah, I just wanted to sort of jump in here, and we're happy to give everything away at half price. There's no problem there at all. but no, I think one of the reasons we're sponsoring this and we're so heavy on data is, the things that gets any, we're a company, I'm English obviously, but I'm based in the US predominantly, and what moves any politician is funding, is cost, dollars or pounds, and is it a big enough problem that, that it gets our attention, and, when we talk about diabetic foot specifically, I mean it consumes 2% of the NHS budget. It can, we're talking billions of pounds. It consumes in the US nearly $80 billion. That's as much as they spend on cancer care, and it has outcomes, mortality outcomes as bad as the worst cancer. So we really can make that analogy, and we should be making it to patients as well. Oh, you have a little bit of diabetes, don't worry, your blood sugar's a little bit high. No. It's insidious. In 10 years, you lose your foot. They should know that. We need to be more aggressive about the prevention and the impact of it. But also, if we can demonstrate that there's such enormous cost, the way we do that's with data, and that's why we've invested in enhanced data and what we're doing here, and we can help with trusts and hospitals. We're doing the same in the US. When we looked at the complete data set for all US healthcare, we built it back up for what they're spending. We can go in and show them that if you can do more prevention, if you can do evidence-based, nice recommended things that are proven to work, implement more effectively, you have enormous cost-saving potential. We're not talking small amounts of money. We're talking billions of pounds, billions of dollars. And what do you do also? The number one reason a diabetic's admitted to hospital is a diabetic foot infection. You free up waiting rooms, you free up beds, you can do more procedures, you improve efficiency. Because I guarantee every politician in this country, NHS waiting lists, for procedures. How many people have private insurance because you can't get a procedure done electively quick enough on the NHS? I mean, it's a system that does great acute care, but suffers because of the burden and everything else. So I think you have enough talking points that are big to get their attention, and the amount of money that's spent on it. And I think if we can use data to demonstrate, to have the metrics then to measure the improvements, because that's the second part of it. That's what we're trying to help out with, because we're part of the solution. We're a tool that can be used conjunctively with all the best practice in multidisciplinary care.
Wonderful.
But data doesn't work without having accountability.
Yes.
Like she said, like if you say, like I'll give an example, right? So the negative therapy thing, what he's talking about is we had a session earlier where there was a wonderful RCT, really beautifully designed, that basically showed that VAC therapy, negative pressure therapy, that was like not as good as just doing something on the side, like our standard stuff. And so as a result, it's a waste of money to do this extra. And you're totally right about patient can go home with a VAC. But the problem, the second you look at that study, at least as a vascular surgeon, I'm like, well, what was the blood flow? Because if all these patients had normal blood flow, yes, ultimately they will heal. But if a patient had an ABI, so less flow, versus another, and then the VAC may stimulate, and then in conjunction with AOTI, you may get it over the finish line. So part of the problem is that our data too, like we're so fixated on that, and we just accept. I mean, yes, it was a Lancet paper.
So I'm just going to bring Roger in, if I may, to sort of say, how can we actually put this into action? How can we socialise this and move this forward?
No, it's all good, and please don't be quiet. I was about to suggest maybe you come along to the next meeting and shout at the Secretary of State for us, because that's exactly what we need.
You got to pay for my flight.
Yeah. So I'm not going to make a comment about the intelligence or otherwise of parliamentarians, but those are framed for them. That's why they're simple.
The guy.
Right?
Everyone heard it.
It's on the record. Maybe strike that one from the recording. But the next stage is the important bit, and that's where we want to put in those really specific bits. And Rachel spoke at the event that we did in February, saying exactly that. What's the stick? So that's the bits we want to put into it. This is a very public-facing for Parliament, for the government. But when we talk to ministers, officials, and DH, the hard stuff comes next. That's where development at the minute.
But even us, though, collectively, like we do not have an answer for you. Like if you ask Rachel, okay, I've got this patient with this ABI set, do you want to do a bypass? Do you want to do VAC? Do you want to do AOTI? She'll make a plan. If you ask me, I'll make a plan. You ask him, he'll make a plan. And we'll all believe that this is the correct thing. So to your point about the 100 voices, the one thing we can do amongst ourselves, instead of focusing on the social stuff that we have no control of and kind of repeating ourselves incessantly, we should sit down and make a decision. If you're the boss in the United Kingdom of limb salvage, and you've done the research and data and put the experience in, and you know that this is the algorithm, then you should be like, this is the way it is, and that's the mandate for government, instead of let each vascular surgeon do their own thing, which is what's happening.
I'm just going to bring Keith in on this. As the president of the Vascular Society, I guess you'll have a powerful voice in the sort of special interest group that sit under the vascular, could have a sort of an audit committee. I guess Patrick is involved in this as well, to understand, right, okay, what can we get data at a national level to be able to have a really powerful data-centered argument that we can take forward.
Well, we've got data on a national level now, as Rachel alluded to. People saw it this morning. We've got NSIP data, which is terrible. Terrible in the fact that even showing that your 5-year mortality, if you've had a toe amputation, is 50%, irrespective of revascularization or not, and that's the data we've got. That's what we're dealing with. The other side, as you say, we've got some power within vascular surgery to do something about it. Well, we got a clear message that yes, we could try some pilots, but we also needed to develop some delivery credibility. I think that the terminology is that we had to show how we can manage the rest of our practice without it being a problem. So if our wait list was shorter than every other specialty across the board, then we would have credibility in our ability to deliver and problem solve. And so we could do them with a bit of support to deal with the real issue of looking to save lives of our patients, which we're not doing at the present moment in time because we're just treating the problem. But our 5-year mortality is appalling because that's what the 5-year mortality of peripheral arterial disease is. So we were challenged with, get your wait list down, develop some credibility, and then we'll look to give you some support. So that's what we can do within vascular surgery, but that's a promise that might not get fulfilled.
Okay. Patrick, did you...
Yeah, I just want to say that whilst the National Foot Attack Pathway sort of aspirations are good, I think that you can't develop that pathway without also delivering a National Foot Attack Registry, because I think in its present form, the NDFA and the NVR, whilst there is some data to actually inform clinicians how to treat our patients better, and systems as well, I think that there isn't that granularity about how foot attack patients present, and sort of, for example, who does the operations, how senior the surgeons are, how severe this presentation is, from the time the patient presents, the sort of surgery that's done, where it is in the foot anatomically, whether they have got vascular disease, etc., the whole patient. And looking at adjuncts like negative pressure wound therapy, topical oxygen, for example, whether or not it makes a difference in the outcome. So I think a foot attack registry needs to be commissioned. That's where the learning, so research and learning will come, and that's how the improvement comes.
Can I just bring in Adam Robinson on this? Because on his presentation was about, we've got a national registry already in the National Diabetic Foot Audit. Yeah. And do you want to just summarise your findings from your presentation and what the lessons are from that?
So yes, I do. Can you hear me? This? Yeah. I mean, what the NDFA has clearly shown is what processes have better outcomes and which processes have worse outcomes. There's a completely linear relationship between your time from referral from a healthcare practitioner to a specialist team and your outcome, and ultimately your risk of amputation. And that is entirely related to how quickly you refer to services. We know that services need to be multidisciplinary. We know that the time to vascular intervention, the time to vascular assessments, all of it relates to the outcomes in the end. So I think we do know what the processes need to be in those circumstances. I'd add, one of the most interesting reports that came out was actually by NHS litigation, who looked at all of the amputation data and all the litigation and amputation data, and it came up with exactly the same things: time to being seen, access to vascular surgery, all of it came as well. And that's an interesting, because that's a very costly, extremely costly. Unnecessary amputations are extremely costly. So I do think we have an idea of what we need to do and what those processes are, but it's how we socialise and implement them, which is the question.
I mean,
started off.
Yeah, it all comes back to the same thing, which is we know roughly what to do, we're just not doing it. And as Anahita said, it's all about the stick rather than the carrot. I think and we always talk about the bottom-up approach and being collaborative. But sometimes you just got to be top-down just to make it happen. And we used to have the 5-day revascularization statistic, and there was money behind that. But then when the money stopped, that changed. Keith, do you want to come in on that?
Well, I was going to say that's really good evidence of how things do work. It is that sequin did make change, but it only made change if you're going to look like you're going to fail. So if you were not going to hit 45-50%, depending which year it was, of delivery of revascularization of your patients within 5 days, you were going to lose a proportion of your acute care budget, a proportion of not your vascular budget, but of your acute care budget. So we got close the first year, and I can tell you the amount your phone starts ringing. And people start looking. You're looking back at your data, where you can make the changes, because you look like you're going to fail, and it's monetarized, but that makes changes. And we finished at 55% when the worry came when we were at 48%, and there was a sudden realization from the trust that it was going to cost them money. And we know that worked across the board. We know there's great evidence to show that actually the delay beyond 5 days costs lives, but still it worked, the sequin, in that it drove care in one direction. We also know, however, that when that monetaristic stipend went, we've drifted back.
So do we know why it stopped, and should we...
It was only going to be lasting for 2 years.
Yeah. Can we bring it back at all? Can we badger government?
No,
or what?
No, that's the unfortunate thing.
How did it happen?
So it's a sequin target. They only run for a certain length of time. We managed to get it for a second year. We had it for first year. They wouldn't run it beyond 2 years. The other thing to say, which I know because I've been around the country now, is that a shocking number of trusts didn't pick up the sequin at all, mainly because they knew that I think they would never be able to achieve it. And they've still got terrible CLTI pathways and are failing universally the 5-day target for inpatients.
I think that's a really good, really important point. I mean, you've got a national picture. You've been to every single unit. You know the data, and you went from work from London to Newcastle, so you can see what the population is like down in the south compared with the north. You kind of see it all. In the centres that are working well, what is it about the centre? What is it about a particular unit that makes you think this is functional, this is working? What is it about that drove them to do that, and how can we replicate that across the country?
So it's a really good question. I think it's wider than the unit. So it's about the whole pathway. So if you're in an area that have got good GPs, good community podiatrists that are picking this stuff up early, you've got a good unit that's running a well-advertised single point of access service that can see the patients within 24, 48 hours or however quickly you want to see them, and good surgeons on site making good decisions rapidly with the bed base that you need, and then but then also post-operatively getting their diabetes under control, their blood pressure sorted out, on the right antiplatelets, surveillance for whatever intervention that they've had done, and really working with them to maintain all of that so they don't get a recurrence in their other leg and come back in managing all of that. That's what makes it good. So Manchester does that exceptionally well, because you've broken down your pathway and you know what you're doing and you know who's providing all of those things. There's also an education element and an access to healthcare problem. So you've mentioned already the north-south divide. It's massive. It's got something to do with culture, patient culture in the north. They don't seek healthcare early. They stay at home. They don't even go and see their GP. It's not that the healthcare professionals aren't picking it up and sending it in. It's just the patients don't show up until
we just tougher up north. That's what you're saying.
Yeah.
Tougher. We're not like you southerners.
But they've not read the paper or seen the stuff that lots of people down south used to come to my clinic and go, I think I've got rest pain, doctor. I looked it up on the internet, or and knew that there was something wrong. Patients in the north are just utterly terrified you're going to cut their leg off, and sadly they sort of live to that as sort of prejudice because they present so late that you've often got no choice but to do that. And so there's an education point of view, but it's also a cultural. So somebody mentioned it earlier, if we're going to make these changes, they really do have to be regional, because you are looking at completely different populations with slightly different problems. And every sort of strategy needs to be targeted to that regional population. I'm seeing lots of people nodding around the room, because London is a very different ball game to Carlisle or Newcastle or Liverpool or Birmingham. They've all got their own separate issues, yes. So my main point is it's not just the units, it's the whole pathway.
I mean, I just say, so thank you for mentioning Manchester, but there is massive heterogeneity within Manchester as well. So Manchester's made...
Sure, but you've given it a bloody good go.
We've tried. But I think one of the key arguments for us in Manchester is not about finance, it's about inequality. And where there is variation, that is where there is interest. Because when it comes to the ICB, their primary focus is inequality. If they're responsible for the £8 or nearly £9 billion health budget, now there's inequality, that falls on their desk. And one of the arguments we've also made, we made sort of three main arguments. The one is, as Marcus was mentioning, cardiovascular. Generally across Greater Manchester, cardiovascular is stroke, coronary heart disease, arrhythmias, and heart failure, which is the great cardio strategy, but not really a vascular strategy. So we put peripheral arterial disease into that. So it's a focus in terms of the prevention strategy. And secondly, when it comes to the inequality of amputation as well, we're quite big on making diabetes and non-diabetes, that the equity in that, and access to MDT care. And finally, it's around No, I've lost my train of thought. I was going to make a really, really good point, and I've just missed it. So I'm going to bring in Mike. You raised your hand. Yeah.
I just want to follow up Mike's point regarding the awareness and the importance. I mean, we're asking, we don't have data, but we have data. We have all the amputation data. I mean, I've seen recently, collected by a private firm, there are 12,000 major amputations going on in the UK per year. 12,000. And people are numb to it. You know, well, actually, when I sort of speak like this, they say, "Oh, Mike, you'll get over it. Diabetics lose their legs. Get over it." You know, and that's from my medical colleagues, actually. So I think there's a slight hypocrisy about all of this. We're not making enough fuss. We've got data on amputations. We've got data on premature death. And we should be speaking about those from the rooftops.
Mm-hmm. And I think to add to that, we can articulate that with the data on what the real cost, financial cost, obviously the suffering and pain and you know, patient cost and family member cost. But if you add the financial cost to that, then I think you get potentially politicians' interest and attitude. And you have we have a unique situation here in the UK. It's a national health system. Yeah, you can dictate what goes on, but it doesn't. It doesn't use its ability to implement care pathways. I mean, you have a thing called NICE, yeah? NICE is not an easy thing to get to make recommendations, but when it does, there's supposed to be something that people pay attention to clinically and at least consider to utilise, and there's no enforcement or no follow-through of it, and you get NICE recommendations, and I guarantee you, do any of you know about the NICE update to the diabetic foot guideline recommendations for treatment? No. Because nobody promotes it, nobody sends it to anybody. So how can you make an informed decision as a clinician to utilise evidence-based medicine if you're not aware of it?
Who's going to push it, Mike?
Yeah, no, exactly. I mean, that's the issue. NHS has the ability to push it. NICE has the ability to push it. Someone has to have the will. And I think if you get to the attention, the size of the problem, both in suffering but cost, then maybe the politicians. And the other thing you could play on is this north-south divide. I mean, I'm from Bognor Regis. I'm about as south as you can get. I need to fall into the channel. But the reality is those disparities exist in every country. I mean, in the US, exactly the same. And it affects access to care. It's how early they represent, and certain subsets of population in the US, the black communities, that they sort of reserve themselves. This is my fate. I get a diabetic foot ulcer. I lose my foot. I might lose my life because that happened to my uncle. That happened to my grandfather, and that's ridiculous. Because physiologically there's no reason that should happen. So the point is, I think you have to just keep elevating this so it becomes such a big problem that someone wants to make a difference. Because it will help them get elected if they can level the playing field on care. In Newcastle compared to what care is showing in London. So again, I think you just have to hammer home the big points to get people's attention.
My final point was that one of the arguments is that in community nursing, if we can reduce, across Greater Manchester we did some modelling, that if we can reduce ulcers by 30%, we will save 219,000 district nurse appointments, which is equivalent of 9 to 9 whole-time equivalent district nurses. And when there's a massive shortage of nurses, we can actually, we may not save money, but we'll plug the gaps in employment. That's another big argument that I made.
I think you need to put this into some sort of like even now we're kind of brainstorming almost, some sort of document and give it a nice name, like we're done being nice about nice.
Okay.
Yeah.
So just that
it'll work with politicians. They love that stuff.
Yeah. So we're recording this to be able to do that. I'm just going to bring in Adam for a very quick point, and then I'm going to let Roger finish off.
Is anyone else hearing a helicopter?
Might be me.
Okay. It was just to say, I just wanted to give an example of an incentive in the NHS.
Oh yeah, flashing Adam there. That's what it is. The batteries are dying.
In an example in the NHS I had direct experience of recently that has worked, an incentive scheme is the best practice tariff for fractured neck of femur. When my mother fractured her neck of femur in rural Wales and was treated locally, and she was operated on within 36 hours. She had orthogeriatrician seeing her within 48 hours. She had a physiotherapist had to be there and everything, and that was a best practice tariff, and that happened in Haverfordwest, which is in the middle of nowhere, and that was almost certainly driven by the best practice tariff, which is similar systems as Equin. So I think that would be an incentive scheme that does seem to work.
Okay.
Somebody must have been driving that, Adam. Who was driving that?
Local orthopaedic surgeons, I think, to be honest.
Right, okay. So we're just in the last couple of minutes. I just want to come back to Roger. So you've heard a lot of the arguments around what we think we need to do in terms of getting data, getting the story right, and getting the call to action right. Do you think we're on the right track, and what do you think we should be doing more? And how can we, the new parliamentary or next parliamentary meeting, which is coming up, how could we use this to, as Anahita said, to really kick our politicians?
Yeah, I think if we can bring her back and some of that US style of lobbying and engagement with government, might be in a better place. No, look, I think as I said before, this is the first step. This is not going to be done this month or next month. And the work that we're trying to do now will probably lead us into the summer. So engage with the VVAPPG as we go into that next step. We're trying to develop some frameworks that will support. We're working with Stella to make sure that anything that comes out of the modern service framework is good for the sector. But it just takes a lot of effort. The thing I'll leave you on is the thing I said in the middle of my presentation. 1 times 100 is not 100 times 1. So we need everybody saying the same message over and over again as loudly as we can to Parliament, to government and to the NHS.
I think that's a wonderful place to leave. I just want to thank AOTI for sponsoring this session, and just to say that they've got loads of data, so if you want to get some data for your local unit to develop business cases, I'm sure they will be, I'm going to speak on their behalf, I'm sure you'll be okay to help people develop those services, get some local data as well to help drive the argument forward. Thank you very much to the panellists, and thank you all for taking part.